I've been talking to John off camera a little bit about what he did this last session of the legislature. So John, pick something. What do you want to talk about?
Well, in terms of family caregivers, my priority bill. So this is my first year at AARP, and one of the things that we AARP nationally have been working on is passing something called the CARE Act. And CARE stands for Caregiver Advise, Record, and Enable. And this came out from some research that had been done that showed that when patients are hospitalized, oftentimes family caregivers are being asked to provide a lot of care post-discharge, and they don't know how to do it.
They're not trained.
Exactly.
They're, as I said in an earlier segment, they're rookies. They haven't done this before.
Yes.
And even if they get the sheet that says do this, there's a lot more to it than just the words on the paper.
Exactly, exactly. And one of the first parts is just acknowledging that a family caregiver is really part of the care team. You know, you've got hospitals, we'll look at, well, the surgeons down, all ranges, you know, the pharmacists, the nurses, the social workers are all part of the care team. And then they forget about the person who spends the single most amount of time with the patient.
Who will be the leader of the care team when the patient gets home.
And family caregivers are being asked to do more and more than they ever used to be. And hospital stays are shorter and shorter through cost savings, et cetera. But imagine if you were asked to clean somebody's wound and manage their medication and give them shots.
In addition to what you're doing before the fall or before the accident.
Well, even if nothing happened before the accident, I mean, except for your life. And I mean, this could even apply to, you know, somebody of any age, really. Like if my wife was in an accident, I would be asked to take care of her. But it is a little bit more common that you know, older folks are hospitalized for a stroke, a heart attack, something like that. So what this bill does, the proposal, it says that once somebody has been admitted into a hospital, that the hospital should find out if there is a family caregiver. Ask the patient, is there a family caregiver? Second of all, record who that person is. Then third, make sure that when there's a discharge about to happen, the family caregiver gets notified so that the person's just not left on the side of the street outside the hospital hailing a cab. And finally, if that family caregiver wants a demonstration on how to provide the care
beyond the instructions,
not just a sheet of paper,
okay,
but actually being shown what to do. I mean, a case in point is that, you know, close family member of mine, I had to learn how to give her shots.
Okay.
And it wasn't just to pull the thing out of the packet. It was like, you know, turn the vial upside down and pull it back and do this. And it's like, I had never done any of that before. And of course, I was nervous doing it. Imagine if all you had was a sheet of paper. You know, being shown, walked through the process is so much more effective for people to learn how to do it right.
You're giving that person the confidence that you need to give the care that is supposed to be there. And then there's that fallout of the responsibility if something goes wrong.
Yeah.
And it really would fall back on the failure to train. So CARE stands for what again?
Caregiver Advise, Record, and Enable.
Enable.
Yes, enable. Because it does enable the caregivers to do a lot better job of caring for someone. Ultimately, this should reduce the number of hospital readmissions. Frankly, the number one cause for readmissions is infections. And
in the caregiving.
yes.
Okay.
So if people are doing a better job cleaning the wound, putting the medication on, less chance there's an infection.
Wonderful. And it goes into effect when?
This will go into effect in January 1st. So we negotiated with the hospital.
This is your advocacy.
Yes. So whenever you're doing a proposal to the legislature, it's usually not so simple and clean that your idea just becomes law like that. You know, we had model legislation that had been passed in other states, and so we took that to legislators and some other stakeholders, because the wrong way to do it is to shock the person who's going to be impacted by this, the hospitals in this case. So we sat down with them and said, this is what our goal is. What do you think? And their first reaction was, we already do this. We don't need laws to make this happen. It's too stringent, et cetera. And so we walked through a lot of it. And yes, some hospitals do a lot of this now, and some don't do it quite so well. And, you know, what those hospitals can learn from the best practices of the hospitals that are doing it well. But there's going to be a lot of variation from hospital to hospital.
I can see that.
And from case to case.
Town to town.
And so the trick is that if you put it in statute, you know, these requirements directly in statute on how to manage your care, that doesn't allow for any flexibility. So the final product is that hospitals must adopt policies that will do these things, you know, but they can be a little bit flexible within their own system, so that they're not being constrained by state law as much as they're being empowered to do something for the caregivers.
So that the net result accomplishes the purpose.
Yes.
And it all goes back to caregivers. Now, when you have that outlying small town, and maybe there is no family caregiver in that category, we've got to put a name down, then what happens?
Well, in those situations, then the hospital figures out how they have to provide the best care for this person, because there isn't always a family caregiver.
Yeah, I didn't know the answer to that question, but I thought, and that's the answer I had hoped for, and that's that puts the burden before the doors open and say you're discharged home and care for yourself, or talk some neighbor into doing it. You really have that stopgap that's just a beautiful, hold it, let's take a breath and say, okay, now what do we do to do what? Not just help the person and the family that might be across the country, but it's that dollar bottom line of that person not coming back in. So that's just such an elegantly inexpensive stopping point to say, let's pay attention to it for a moment before we go to the next problem.
Right, and what this legislation also accomplishes is that they have to ask that question, do you have somebody who's going to take care of you when you're discharged? And if they say no,
if the patient says no,
then that tells the hospital they need to look at this a little differently.
And if that person gives the name, does the act then have, or the policies to be implemented would suggest or urge that they then have a step of contacting that person and telling them when the discharge?
Yes.
And if that person says, I don't have a car, then it again is a place to say, let's make arrangements, because the foot isn't walkable, we need to transport. All sorts of good things can come out of that.
Right. It really encourages much better communication with really what is the entire care team.
Sure.
You know, there's so many social determinants of health, how somebody lives their lives, that this helps really identify what are this person's real problems. And now that we have this new system, at least for Medicaid, where it's capitated and they have to look at how do we prevent this person from coming back into the hospital, the hospitals aren't going to use that model exclusively for Medicaid. They're going to look at, well, this kind of works with all of our patients. And so,
should.
And the federal laws, the Affordable Care Act, are actually fining hospitals if their rate of readmission is too high.
Right.
So there's a financial incentive for them as well at this point. So.
Excellent. Okay. Thank you. We've got one more segment.